Good morning, everybody. Thank you for coming. This is a very engaged audience, as Dr. Rowland said, and it's a testament to what's been done by Dr. Patel and Dr. Norris, building the momentum. I'm a gastroenterologist. I'm going to try and dig myself out of the hole that Dr. Maitland put me in. For a fellow gastroenterologist, have done 10 colonoscopies on a patient. But I'm a neurogastroenterologist, and these are my disclosures. But just the objectives to just define for this audience what neurogastroenterology is and who neurogastroenterologists are and why they may be the right gastroenterologist type to help understand and manage GI symptoms and EDS. And then parallel cohorts, I've studied gastroparesis patients, so maybe some lessons learned from that group of patients that can be applied. And then some promising and evolving management strategies that I'm involved in researching. So neurogastroenterology is defined as the neurology of the GI tract, liver, gallbladder, and pancreas, and that encompasses the control of digestion through the enteric nervous system, what we call the second brain, the central nervous system, the first brain, and the integrative centers of the sympathetic ganglia. And basically, this is popularized as the gut-brain axis. It's more gastroenterology than it is neurology, but we hope to change that neurologist by neurologist for now. It is an international organization. There's a presence in the United States, Latin America, Europe, Asia, and Australia, and they have meetings every second year in an international location where people get together, and we have our own journal. So just to introduce the subspecialty to people. We've gone through a transition. We used to call a lot of our conditions functional GI disorders, which means that you have a normal endoscopy, normal CT scan, normal blood tests, yet patients still have symptoms. So we had this myriad of functional diagnoses, and they're grouped according to esophagus, stomach, small bowel, and anorectum. And now we're moving to the terminology of disorders of gut-brain interaction. Now, patients don't like either one of these terms because it leaves a lot of gray room for interpretation and classification. So there's been a Rome group that comes together in a beautiful Rome, and they come up with criteria for a number of these diagnoses, and they're moving from their fourth iteration to fifth iteration with this terminology. Now, with the time that I have, I'm going to highlight two papers from the GI literature that I find are important to Ehlers-Danlos and hypermobile spectrum disorders. This is one paper that came out a number of years ago, and this is the second paper. If you guys want to read this in more detail than I'm highlighting, please feel free to do so. So in this first paper done by classifying patients with Rome 4 criteria, they surveyed over 600 hypermobile EDS patients and hypermobile spectrum disorder patients and matched them to patients in the UK. And they filled out these questionnaires that have been validated and looked at other metrics. So what they found is that patients with HEDS and HSD had significant higher prevalence of these disorders of gut-brain interaction across the gut, the large intestine, the gastroduodenal foregut part, esophageal, and anorectum. And what was really striking was the amount of abdominal pain that these patients suffered from. So usually in the general population, patients had everyday pain 14% of the time, whereas patients with HEDS and HSD had everyday pain in more than 3/4 of the patients. So that's pretty significant compared to patients with GI problems. So these two diagnoses in particular were more common in patients with Ehlers-Danlos, and I'm just going to say Ehlers-Danlos to quit saying both of them together. But irritable bowel syndrome, which is thought to be small bowel predominant, and functional dyspepsia, which is supposed to be stomach-related symptoms. And these patients had more GI healthcare utilization, so they saw a gastroenterologist, maybe many gastroenterologists over time. They tried many GI medicines that are antacids. A lot of analgesic use, and we've seen from the Norris lab that sometimes these analgesics don't work as well for patients with EDS, neuromodulator and laxative use. So this brings us to a little bit more of a recent study. This was just done published last year, where they looked at about over 1,000 patients with HEDS and merged two data sets that they had already been accumulating, the Rome 3 and Rome 4. And they looked at somatization, POTS, autonomic function, symptoms, psychological factors, and quality of life. And then they'd used machine learning to group these patients and see if they found a pattern. And these are the clusters that they found. Sorry, this chart is hiding the definition of the clusters, but cluster 0 is actually patients with functional dyspepsia and irritable bowel syndrome, and HDS. Cluster 1 is patients with just irritable bowel syndrome and HEDS, and cluster 2 is HEDS patients without any GI diagnosis. And based on these 3 clusters, they found that cluster 0, which has the functional dyspepsia present along with irritable bowel syndrome, they had the most somatization in these validated scores. That means the most feeling symptoms related to their gut. And then they also had the worst healthcare related quality of life, as well as the highest depression and anxiety scores, and more POTS. So these were the sickest patients, the ones that had symptoms related to their stomach, as well as IBS. And when they looked at autonomic function tests, just by symptoms alone, this isn't by physiological testing, they tended to have more gastroparesis-like symptoms. So we'll talk about this. This is kind of a big hot debate in our GI field as to what is functional dyspepsia, what is gastroparesis, and are they really that different? So functional dyspepsia is thought to affect about 7% of the population, and you meet these symptom-based criteria by Rome 4, and you have these symptoms: postprandial fullness, so fullness after meals, like a lot of our patients get really full after a couple of bites. That's what this is. Feeling full really early, and then epigastric pain in this top part of the stomach, and burning. A much smaller prevalence of gastroparesis, where you have similar symptoms, including nausea, vomiting, and you need a actual test where you eat a meal to show that you have a slow stomach. So here we can see that these symptoms, really the predominant symptom between these two conditions, functional dyspepsia and gastroparesis, are identical. So they don't differentiate by their most severe symptom. They also don't differentiate by how severe their symptoms are rated on a score. So the symptoms are identical at baseline between these two conditions. And when they eat a meal and they're challenged by eating a meal, their symptoms are still identical. They overlap quite a bit. So this study highlighted that if you took patients and did a gastric emptying test, how many people have had a gastric emptying test? How many people liked their gastric emptying test? No, right? So they looked at 250 patients. Patients had gastroparesis at baseline. That means they had a slow stomach. And then they repeated the gastric emptying 4 years later. 40% of these patients went from a slow stomach to a normal emptying stomach, and 40% went the other way, from a normal emptying stomach rate to a slow stomach emptying rate. Guess what happened to the symptoms? Nada, nothing. So the emptying rate and the symptoms aren't very well correlated, even though it's part of the reason to make the diagnosis for gastroparesis. So all this data suggests that these two conditions, whether you have a slow stomach or not, really the symptoms aren't different. So, but the way people respond to treatment may be different, and we'll get into that here. So patients that use nortriptyline neuromodulators, so neuromodulators are generally antidepressants that are antidepressants at higher dose, but in GI we use them at very low doses to just block the nerve signal going from the gut to the brain. And one of them is nortriptyline, and they found that if you have a slow stomach, if you use nortriptyline, symptoms don't improve. But if you have a normal symptom, they may improve. So gastroparesis doesn't respond to pharmacologic therapy or neuromodulator use. This is just highlighting the problem that I have with a lot of my patients with gastroparesis. They pooled 25 randomized control trials. So these patients in randomized control trials are followed the most closely, right? And they tried all these drugs. In diabetic gastroparesis particularly, 16 drugs were no better than the sugar pill. So diabetic gastroparesis doesn't respond to medicine. And then So now the powers to be and the Rome Foundation are separating these gently between idiopathic gastroparesis and diabetic gastroparesis, the two predominant type. And guess where Ehlers-Danlos falls? Idiopathic, right? Idiopathic is where most Ehlers-Danlos patients fall. Idiopathic, by definition, means there's no underlying cause. We can all say that Ehlers-Danlos is an underlying cause of patients with potential gastroparesis or functional dyspepsia. So I've kind of made the counter-argument that diabetic gastroparesis and functional dyspepsia and idiopathic gastroparesis are different, and Ehlers-Danlos may be a different category. And we just don't know because we don't diagnose these patients properly and then follow their treatment in an organized fashion. So yet to be determined here. I've particularly been interested in diabetic gastroparesis because these are the patients I've been seeing. I just moved from Georgia after spending 10 years in Augusta. And Augusta is no different than Charleston in the amount of diabetes that it has. So if you can look at this map from 2004 to 2021, we're now in Charleston. Look how dark South Carolina and Georgia are. 1 in 3 kids born in the states of Alabama, Georgia, and South Carolina are going to have diabetes. So we are in a major pandemic of diabetes. So this is what the literature will say the 3 top controversies are gastroparesis. This is what my patients tell me. Do I have to keep repeating this gastric emptying test? We already said we have patients that hate it. My patients do hate it as well. What causes my symptoms and how can you help me? So this is the stomach emptying test. It's calibrated for the number of calories, the amount of fat, protein, and carbohydrate content, following this 2-GOS protocol. And before, radiologists who are very busy would just stop the test at 2 hours, but you miss half the patients with delayed emptying if you don't do the test until 4 hours. So it's very important to do it 4 hours, and if you have more than 10% of that meal radio-labeled at 4 hours, that's diagnostic gastroparesis. Those pretty pictures aren't what the meal looks like. It looks like this on a hospital table, which is disgusting, and if you're nauseous, you definitely don't want to eat this. So hence the why do I have to repeat this test? So we mentioned some of the problems with this, right? No correlation between changes. All these medicines speed up the stomach, but the symptoms don't get better. And that's been kind of the problem. And then the symptoms may get better, but the stomach emptying doesn't change. So these are the 3 pillars of diagnosis for gastroparesis. You need these 6 cardinal symptoms, no mechanical obstruction that's done by radiology or endoscopy, and then this 3rd criteria, maybe not as important. The stomach is much more complex than any area of the gut, right? So the top part of the stomach is called the fundus. That actually relaxes to accommodate food and allows acids and proteases to break down protein in the top part. The bottom part of the stomach actually contracts in a rhythmic fashion and pulverizes food particles to less than 3 millimeters. That gets sieved through a closed pylorus or a valve at the end of the stomach. And then if they're smaller than 3 millimeters, they get absorbed in the small bowel. And then at rest, you switch into this kind of sweeping motion where you sweep non-digestible residue out of the stomach. So that's these phase 3 of migrating motor complex. So that's the switch from fed to fasting states. And my patients with this kind of frustration about the stomach emptying test, well, these guidelines to do the stomach emptying test were made in 2008, right? We're in 2025. Still, only 37% of centers that do these stomach emptying tests follow all the guidelines to do the stomach emptying test correctly. So, especially out in the community, we really struggle with following the protocol, and that's why sometimes we have to repeat the stomach emptying test. So, the state of gastroparesis with this diagnosis is super depressing. You have 4 times the rate of anxiety and depression compared to matched patients in the population. And the troubling fact here with gastroparesis, and this may translate to Ehlers-Danlos, is 13.4% of patients would accept a risk of death to try a hypothetical medicine. So, I mean, very desperate patients. So how can you help me? The only medicine FDA approved for gastroparesis is metoclopramide, and it's problematic. It can cause a Parkinson's-like syndrome where you have tremors, or you can have a permanent tongue rolling condition that a neurologist sees called tardive dyskinesia. We have a gastric electrical stimulator, but that's not strong enough evidence to use in everybody. It's only used for compassionate use where nothing else works. And then we already said that 16 drugs are no better than sugar pill. So there's a huge unmet need. Now, I'm very in key of when the GI societies get together and make guidelines, but the problem is when they have weak evidence, they come out with, you can't do anything for these patients. So you can see that we have some that suggest use of metoclopramide and erythromycin, 2 medicines, but it's on very, very low level of evidence, right? So you're not very confident writing these for your patients, but everything else, including I think GPOM, where there's a talk later, there's our society is saying don't do that. There's not enough evidence for that. We're actually recommending against that for patients. So it suggests that prematurely coming out with society guidelines can bind a provider in terms of taking care of their patients. So we need better diagnostic testing and we need better treatment for these patients. I'm just going to zoom through these because we're running back late on time, but there's other ways to check the stomach emptying. This one, which got withdrawn from the market, which hopefully the FDA improves for more patients, gives a whole gut profile. It only gives us stomach emptying, but small bowel transit time and colonic transit time. Because if you think about conditions like HEDS, it doesn't just affect the stomach, it affects the entire gut, right? The colon, the small bowel, anal rectum. So having a test like this will give you a whole gut profile, which is very helpful. And then some of this relates to that switch from fed to fasting state, which can be helpful in patients, but again, that's not available. This is a replacement potentially for it. And then we know in our gastroparesis patients, half of them have slow colons as well as slow stomachs, so helpful there. And then when the gastroparesis patients are followed over time, 60% of them have moderate to very severe constipation. And the symptom severity of their upper symptoms, their nausea, vomiting, feeling full real fast, track better with how severe their constipation is rather than anything else that we measure. This is, like our cardiology EKG, this is an EGG, egg. It measures the electrical activity of the stomach, so this is promising. But if you look at patients with nausea and vomiting, only a third of patients have abnormal rhythm of their stomach, so not something that would really find a lot of abnormal rhythms. So I think this is kind of telling in gastroparesis, like it is with HEDS. We're failing our patients. We're not using medicines. We're using more opiates, and we're having increasing hospitalizations. So this is what happens when you lack treatment for these patients. Just switching gears, what is causing their symptoms? Well, there's some evidence to show that there's certain autonomic function testing disturbances that track better with diabetics that have normal emptying versus delayed emptying. And there's this condition called diabetic autonomic neuropathy, which I know that HEDS patients have POTS and autonomic neuropathy as well, so this may be relevant. In fact, for our diabetic patients, they don't typically have heart attacks like most people have heart attacks. They have silent heart attacks. They don't have that left-sided chest pain that radiates down their arm. They have just silent heart attacks, and they present in worse shape to the hospital. So when they have this cardiac autonomic neuropathy, they have a 50% chance of dying in 5 years from these silent heart attacks. But diabetic gastroparesis precedes the development of heart problems with autonomic neuropathy. And the key thing here is that autonomic neuropathy doesn't just affect one side of the autonomic nervous system, parasympathetic, your rest and digest, or your sympathetic, flight and fight when you have a line in your face, right? It affects both sides of the nervous system. Another key thing that might give insight as to why these patients have symptoms is a disconnect between what's happening in the gut and the brain. Diabetic patients have neuropathy in their fingers and toes. They lose sensation. They can't feel things. They sometimes step on a dirty nail or something sharp, and then they'll have a bad wound that doesn't heal very well. But they also have a numb gut as well as numb fingers and toes. But despite having a numb gut, they still have really bad symptoms. So that suggests that maybe the nerves talking between the gut and the brain are firing on autopilot, causing distress to the patient. So we see those changes when we stimulate the gut with a little bit of electricity, and the signals in the brain are a little bit shifted than they would be in normal patients. Excuse me. So just some other points here that support that symptom. So diabetic gastroparesis was described in 1958. And it was before we had endoscopy and we had widespread use of insulin. And before we had acid reflux medicines. So how do we treat ulcers in the 1950s? we cut out the bottom of their stomach and we cut both vagus nerves. And patients with this kind of, after the surgery, would come in, have x-rays, and they'd have food in their stomach. So everybody thought that because the vagus nerves were cut, that's why they had poor motility of their stomach. And then diabetics without this surgery would present the exact same way with nausea, vomiting, have x-rays with food full of stomach. So everybody thought that it was a vagal problem. So that is why some of this non-pharmacologic neuromodulation has kind of taken off, because we know the medicines don't work for this condition. Vagal nerve stimulations can stimulate the pacemakers in the stomach, and they can also decrease the inflammation of the stomach. And this has been tried in diabetic gastroparesis with a variety of techniques. The gamma core on the bottom is where they stimulated the vagus nerve in the neck non-invasively with a magnet. And they found that these patients had some improvement in their symptoms, but about a third weren't able to tolerate this device, which has led to stimulating the vagal nerve branches in the ear. And this has an indication in pediatrics for functional abdominal pain that is now approved for patients up to the age of 21. What drew me to this is we were using TMS in the peripheral spine, which our psychiatry colleagues have been using for 30 years, stimulating the brain for treatment of refractory depression. And there's been some studies as to when you take a dog and you cut their vagus nerve completely and you stimulate the nerve to the stomach from the sympathetic side, you actually get gastric contractions. And when you block the stomach muscles, those contractions get stronger in the stomach. So potentially stimulating this nerve would be of benefit. So looking at the innervation of the stomach, we see that these branches in the mid-back from T5 to T10 innervate the stomach. So my lab has taken this magnet used for depression and put it in the mid-back and stimulate these nerves, following our work in fecal incontinence where we stimulate the lumbosacral nerves with a magnet. And we found that this low-frequency stimulation improves symptoms of fecal incontinence based on what we think are these mechanisms. So moving the magnet up to about where the scapulas are has showed to improve. I was patient number one. Those are unflattering pictures of myself. But we found that when we finally got our protocol right, with gastroparesis, we actually don't use day-to-day symptoms because day-to-day symptoms vary very much in these patients. We took a 7-day average of symptoms before stimulation, the week of stimulation, 2 weeks out, and 3 weeks out. And we found that from that first week of stimulation, we had a 75% decrease in average of week symptoms that almost went completely away by 2 and 3. And it wasn't just 1 or 2 symptoms of gastroparesis, it was all the symptoms of gastroparesis that got better. So we took this and applied to the NIH for a grant with Harvard, and we're now funded to do a sham-controlled trial, so a fake magnet stimulation trial and a magnet stimulation trial at 2 different intensities in diabetic gastroparesis, following them out to 4 weeks. And this is a characteristic response by even 1 day of stimulation. They have a substantial drop in their symptoms that gets maintained out. What about the TMS people love finding exactly the right location and orientation of the magnet as to where to stimulate the brain. The good thing is this nerve lies in pretty much the same orientation in the back. So we modeled this with physicists and found that we have the max negative potential, max positive potential right on top of our nerve using these models. And if you rotate the coil a couple of degrees here or there, it doesn't really affect the field that much. So you have good treatment effect. So just some take-home points. I think diabetic gastroparesis and then by extension, maybe gastroparesis and Ehlers-Danlos Syndrome are different than and should be lumped differently. And we need to really characterize patients a lot better with, unfortunately, physiological testing, but newer physiologic testing, and follow them and see how they respond to treatment. But it should be a little bit of a different category. And then I think that treating with medicines may not do the job, and I think many patients with these problems have gone through a lot of medicines and had failure, and that neuromodulation may be an alternative strategy. That will end, and thank you guys for your time.